This is a simple algorithm for how you will manage respiratory distress. And initially, you assess the baby in the delivery room, provide warmth, position the head, clear airway, dry the infant, and stimulate if necessary. Same steps as in the NRP. You evaluate the respiratory rate and oxygenation. If the rate is more than 60, that indicates tachypnea and respiratory distress. One of the criteria is met. You administer oxygen if the baby is hypoxemic. You are monitoring the saturation as well. So if the baby is transitioning and you suspect TTN, you obtain the chest X-ray, blood gas, blood count, and blood culture. You begin empirical antibiotic therapy. If it is a late preterm or term infant and the chest X-ray is consistent with transient tachypnea, it's most likely transient tachypnea if newborn has a diagnosis. You continue oxygen supportive management and consider CPAP. If it's a preterm infant with chest X-ray consistent with RDS, you supplement oxygen. Surfactant should be considered according to the oxygen requirement and your ventilatory requirements, and begin mechanical ventilation if the blood gas suggests respiratory failure. If it's a late preterm, term, or post-term infant with hypoxemia and the chest X-ray is suggestive of infiltrative disease, you treat the lung disease. Surfactant might have a role in these conditions as well. If the chest X-ray has clear lung fields, you need to do echocardiography to differentiate between primary cardiac and persistent pulmonary hypertension. This is a very important step because if you don't recognize this and you ventilate the baby assuming there is underlying lung disease, or you give surfactant, you may end up worsening the clinical situation. If the baby has received positive pressure ventilation, again, you go through the same steps. If the baby is well, you just observe. So this is a very useful algorithm for you to get an overview. We discussed already what the supportive management is.